Giuliano Ramonderi to start the webinar. Welcome.
Oh, I welcome you, everybody. Thank a lot, Tim, for your work, for having put together all the speakers, and thank you for the speakers, or to the speakers for the time they are taking for discussing with us a very important topic, I believe. I think I will have something to say later about the journal, about the aim of the journal, but I think we can get started, Tim. Can get started, and that's now your task. Go ahead. Thank you.
Thank you so much. Well, I want to thank Professor Ramonderi, who's the executive chief editor of Hepatoma, for his partnership and collaboration and hard work of the team setting up this webinar today. As noted, my name is Tim Pollock. I am a hepatobiliary surgeon, chair of surgery here at The Ohio State University in the United States in Columbus, and I'm extremely happy to be with you all today to discuss a topic that is near and dear to my heart and important to all of you. We are incredibly lucky to have an internationally renowned panel of speakers to talk on a whole host of different topics around the challenges and opportunities for treating intrahepatic cholangiocarcinoma. Before we get started, I just want to highlight some basic etiquette tips on this webinar today. We ask, if possible, that you change your name into English on the website, so we know who's on the call and that we can interact with one another during the discussion sessions. We ask that while the speakers are talking, that you keep your cameras off and your microphones on mute, so there are no distracting noises or videos in the background. As noted, we will be having discussion sessions after section 1 and section 2 of this webinar today. And these discussion sections will be about 15, 20, 25 minutes long. And we've purposely put them in there to encourage robust discussion, not only among the speakers, but also among all of you as participants. So at that time, we would ask that you can turn your video on and unmute yourself, perhaps raise your hand, your virtual hand, and we will call on you so we can hear from you. You can also put any questions or points of discussions in the chat room, and I will also be checking that, and we'll be happy to verbalize those notes in the chat room for everyone. And so, and then finally, all registered participants will be offered a certificate at the end of the webinar. So please be sure that you are registered for the event, or at the end, you contact the editorial office if indeed you desire a certificate. So here is the panel for our first session. As noted, we have an esteemed group of individuals that will be touching on various aspects of intrahepatic cholangiocarcinoma, from the epidemiology and risk factors to pathology, imaging, and then I'll be talking about surgical management. And then in the second session, we'll be talking about non-surgical management, including systemic therapy, targeted therapy, as well as liver-directed therapy for intrahepatic cholangiocarcinoma. So with that, I would like to introduce our first speaker. We're very lucky today to have with us Dr. Kimberly Washington, who is an assistant professor in the Department of Surgery at Texas Christian University. She is a hepatobiliary surgeon and someone who is well-versed in a multitude of specialties in HPB surgery, both primary and secondary tumors. And today, she's going to be discussing with us the epidemiology, incidence, as well as geographic and overall risk factors associated with this disease. So with that, again, I'd like to welcome Dr. Washington, and I will turn the screen over to her. Kimberly.
setting this up here. Yeah, I think we should be set. Well, thank you so much to the organizers of this webinar for allowing me to present and discuss the epidemiology risk factors, and I'll highlight a little bit of the disparities that are seen in mostly the United States, but I'm sure some of those factors can be kind of similar around the world, mainly due to the differences in socioeconomic standards and factors worldwide. So we often discuss statistics and epidemiology of a disease process, and it can't be overstated how important this practice is, particularly in rare diseases like intrahepatic cholangiocarcinoma. The intent of epidemiology is to prevent or reverse negative health outcomes. And I hope to show in the next 15 minutes a sweeping overview of intrahepatic cholangiocarcinoma and how our study of incidence of disease and impact can improve outcomes, particularly for those in lower socioeconomic status. Intrahepatic cholangiocarcinoma is rare, accounting for about 3% of gastrointestinal malignancies worldwide. It comprises about 15% of all primary liver cancers, second only to hepatocellular carcinoma. Intrahepatic cholangio is infrequent in patients younger than 40 years old and has a peak incidence between the 5th and 7th decades of life. Most recently, it's been thought that the increasing incidence is truly an increase and not a function of earlier detection, since the increased incidence is independent of tumor size or stage. So there's a huge discrepancy in worldwide rates of intrahepatic cholangiocarcinoma, with higher rates in Eastern Asian countries compared to Western countries. The intrahepatic cholangiocarcinoma rates vary from as high as 96 per 100,000 in men and 38 per 100,000 in women in northern Thailand, to as low as 0.2 and 0.1 per 100,000 men and women in Australia. So a very, very significant difference in numbers as you move from country to country. As many of you know, this disease is often asymptomatic in the early stages and thereby makes it harder to treat. For those detected through screening and who present with early stage disease, cirrhosis is not only a common etiologic factor, but a condition that can complicate or limit the available treatment options. Therefore, the best opportunities for improving the care of these patients are either through prevention of underlying liver disease or identification of at-risk patients, ensuring that they're appropriately screened for the development of primary liver cancer. This highlights just how little is known about the epidemiology of intrahepatic cholangiocarcinoma, particularly in Western countries. Many ICCs are detected during hepatocellular carcinoma screening in at-risk patients or those who are undergoing treatment for presumed diagnosis of hepatocellular carcinoma. And as such, many of the commonly cited HCC risk factors are shared by ICC. Therefore, it's believed that inflammation and subsequent injury to the bile ducts plays a role in carcinogenesis. So just looking at a few of the risk factors for intrahepatic cholangiocarcinoma, and again, this may sound somewhat like a broken record for HCC, but as stated before, the reasons are they tend to be found in patients who are being screened. Cirrhosis has a 10 to 20-fold increase in intrahepatic cholangiocarcinoma. Viral hepatitis, including Hep B and Hep C, provide about a 2-fold increase in intrahepatic cholangiocarcinoma risk. And although there are very few studies that assess the association between alcohol use and intrahepatic cholangiocarcinoma, there is a weak association between the development of cirrhotic liver disease in the context of alcohol use and cholangiocarcinoma. Tobacco use as well. There's meta-analysis of case control studies that shows smoking has a non-significant 31% increase in odds of intrahepatic cholangiocarcinoma, but there was also, in comparison, a population-based study where smoking was associated with a statistically significant 80% increase in odds of intrahepatic cholangiocarcinoma. So smoking, as everyone knows, has been one of those factors that we found in association with almost every malignancy. So of course, intrahepatic cholangiocarcinoma will be no different. There's a SEER registry data as far as in relation to diabetes that suggests a greater than 50% increase in likelihood of cholangiocarcinoma in patients with diabetes. It's unclear if diabetes results in liver damage, which causes non-alcoholic fatty liver disease, or if diabetes itself increases the risk above and beyond that associated with chronic liver disease. That's an important unanswered question that we probably should study a bit more. Obesity, again, a meta-analysis in US population-based cohort identified overweight and obesity being associated with 56 to 70% increase in risk of intrahepatic cholangiocarcinoma. Interestingly enough, a Danish study didn't find a similar correlation. So there's much more that needs to be done in order to determine whether obesity is truly a risk factor. Of course, choledochal cysts, we're very familiar. These tend to cause more extrahepatic cholangiocarcinomas, but can also develop intrahepatic as well, particularly in the type 4 and type 5 choledochal cysts. Similarly, primary sclerosing cholangitis, 7 to 15% of those patients will develop intrahepatic cholangiocarcinoma. And hepatolithiasis, the process by which that develops, that causes ICC, is thought to be related to biostasis, which leads to bacterial infection and chronic inflammation. Of course, we can't avoid discussing parasitic infections, particularly in Korea and Thailand. They afford a 2 to 5% increased risk. And just for historical significance, Storatrast was a contrast agent that was banned about 50 years ago, but exposure to it led to a 300-fold increase risk of developing ICC. There are a couple of things that have been studied to decrease risk of ICC. One, in a population-based study, they identified patients who were diabetics who were treated with metformin, noted a lower risk. This has only been in one study, so more information is necessary there. And of course, aspirin, because of its anti-inflammatory effects, has been thought to potentially have an effect on decreasing all malignancies that are related to inflammatory states. And the Liver Cancer Pooling Project suggested that aspirin use lowered the risk 36% in men, but no significant difference in women. So there's more to learn when it comes to the epidemiology and the risk factors associated with intrahepatic cholangiocarcinoma. And now moving on, the last few slides to healthcare disparities, particularly for this disease, and this is catching on for many malignant states. The SEER database studies have identified a higher incidence rate of ICC in, as well as poor survival in men and older individuals. Additionally, in the US-based studies, they've also identified in a couple of different database studies the higher incidence of intrahepatic cholangiocarcinoma in Caucasian Americans compared to African Americans. However, their all-cause mortality is similar between the two groups, which is interesting. Additionally, we should learn more about the impact that age, for example, race, ethnicity has on ICC, as well as the risk factors and strategies to effectively prevent this disease. And one example to highlight the importance of paying attention to the differences that are seen in various disease processes, it's that in patients with ICC, we know that it typically happens in older age groups. So analysis of the impact of age on incidence and survival is necessary to determine whether risk factors for intrahepatic cholangiocarcinoma in younger individuals differ from those in older individuals. And that's one way we can use that data to learn more about this disease process. This slide, this is actually a study that reviewed about 11,000 patients with histologically confirmed intrahepatic cholangiocarcinoma between 1995 and 2014. And they found that age-adjusted incidence rates were higher for males and females, the higher for Asian Asian and Pacific Islanders than Caucasians, and that Hispanic ethnicity afforded a higher incidence of intrahepatic cholangiocarcinoma compared to non-Hispanics. And just looking a little bit more detailed at this particular chart, this looks at the 1 year and 5 year. This is disease-specific mortality. And it shows that particularly in American and African Americans, their disease-specific mortality is higher at 1 and 5 years, and similar for Hispanic Americans. And so this is something obviously that we need to hone down a little bit on. These are the Kaplan-Meier survival curves, again, showing a poor 5-year overall survival and disease-specific survival in individuals over the age of 45 compared to those under 45, as well as poor outcomes in Hispanics compared to non-Hispanics. And lastly, this study I found very interesting in that it reviewed a total of 100,000 patients who were admitted with a diagnosis of intrahepatic cholangiocarcinoma, of which only 7,000 subsequently underwent an operation, which represents about 7% of that population. And their study identified that patients who were younger were more likely to undergo an operation. Those who were Caucasian American were more likely to undergo an operation. Those who had private insurance, so a payer source, were more likely, as well as those who had a lower comorbidity index, which I'm sure that comorbidity index correlated well with age. And so just figuring out ways to understand better this data, I think is very important. So lastly, because the incidence of intrahepatic cholangiocarcinoma is increasing worldwide, including in the United States, it's important that we identify the needs that we have in this particular disease as far as epidemiologically. Since it's rare, we need comprehensive population-based studies that assess risk factors and determine if mitigation techniques exist and if we can implement them. We also need robust data analyzing socioeconomic factors and their impact on diagnosis, treatment, and survival. We'll stop sharing here.
So thank you, Dr. Washington, for that great talk and overview of some of the risk factors and outcomes for treatment of patients with intrahepatic cholangiocarcinoma. And I have a number of questions for you, but I'll save those for the discussion time. So we'll move on to our next speaker. And our next speaker is Dr. Wenming Kong. Dr. Kong is a professor and director of the Department of Pathology at the Eastern Hepatobiliary Surgery Hospital in Shanghai, China. And we're very lucky to have Dr. Kong with us today. He'll be speaking about the pathologic diagnosis of intrahepatic cholangiocarcinoma and highlighting some of the work that's been done by the Expert Consensus Conference in China around the pathologic diagnosis of this disease.
It's kind of overview stuff. So
Dr. Kong?
Okay, can you see my slide?
Yes, we can.
Okay. Distinguished professors, ladies and gentlemen, good morning and good evening. It's my pleasure to attend this special webinar to talk about improved fine pathological diagnosis of intrahepatic cholangiocarcinoma. A brief introduction to our new expert consensus on pathological diagnosis of ICC in China 2022 edition. Firstly, I will say a few words about the background of ICC pathology in China. Just now, Professor Washington has just systematically introduced the epidemiological study of ICC worldwide. A recent epidemiological study of ICC in China showed that the incidence of ICC is on the rise, especially among people over 65 years old. Among the numerous of risk factors for the development of ICC, HPV infection is probably one of the most important factors in China. Of the 1,900 resected liver tumors confirmed by pathology in our Eastern Hepatobiliary Surgery Hospital, Shanghai, 83.6% were hepatic malignant tumors. Among them, HCC and ICC accounted for 90.2% and 8.2% respectively. According to the data of our pathological department, the number of surgical resections of ICC seems to exceed that of HCC in some years. From the perspective of diagnostic pathology, the diagnostic strategy of ICC in the current WHO classification may have something to be further refined or explained. For example, how to select the first-line antibodies from many immunohistochemical markers as mentioned in this table. And besides the rules of diagnostic molecular pathology, the IDH1 or 2, FGFR2 maybe have some rules in drug-targeted therapy. So for these questions, we formed an expert group to develop a consensus statement for ICC pathology practice. We define that ICC is a tumor arises from the secondary branches called the segmental bile duct to the smallest branches named the canals of Herring of the intrahepatic biliary system. These three bile duct groups correspond to the three main subtypes of ICC. Okay, let's see the morphological characteristics of large duct type ICC, which arises from the intrahepatic large bile duct group, showing columnar cancer cells arranged in irregular ductal patterns and are more prone to aggressive behavior. Some immunohistochemical markers, such as S100P and MUC5AC, are staining positive. This type of ICC has the worst post-operative prognosis among ICC subtypes. This figure shows the typical large duct type ICC with columnar cells and mucus screening cells and inviting portal tracts in surrounding liver tissues. S100P staining is positive. Small duct type ICC arises from the intrahepatic small bile duct group, showing cuboidal or low columnar cells arranged in regular ductal patterns. They are less aggressive than large duct type ICC. See, reactive protein and encapsulating are useful biomarkers to confirm this kind of ICC. Here, we need to be aware that S100P may also be positive in small duct type ICC, depending on which columns of antibodies you choose. IDH1 or 2 mutations and FGFR2 fusions or rearrangements are representative biomarkers for drug-targeted therapy of small duct type ICC. The post-operative prognosis is much better than that of large duct type ICC. This slide shows the representative small duct type ICC with cuboidal cancer cells arranged in regular and dense small ductal structures with encountering staining positive. Cholangiocarcinoma, CLC, is a unique and distinct subtype of ICC, which originates from the smallest branches of the intrahepatic biliary tree, characterized by a well-differentiated anastomosing tubulus within the hyalinized stroma. The post-operative prognosis of CLC is generally excellent, better than large and small duct type ICC. Figure A shows that CLC consists of small cuboidal cancer cells arranged in branching granular structures and embedded in collagenized stroma. Figure B shows that HCC-like ICC is composed of polygonal cells with eosinophilic cytoplasm arranged in trabecular patterns, histologically resembling HCC. So be careful, it's a diagnostic potential, diagnostic pitfall, even for experienced pathologists. However, HCC-like ICC expresses cholangiocytic markers such as CK7 and CK19, but not hepatocytic markers such as arginase 1 and hepatocyte paraffin 1. The left figure is one of our liver biopsies, and the right figure is a case from the Journal of Histopathology. From the point of view of diagnostic pathology, it seems no problem to diagnose HCC in these two cases if you only look at HE slices. However, the immunohistochemistry confirmed that tumor cells show biliary but not hepatocyte differentiation. Therefore, both diagnoses are HCC-like ICC. Another special subtype of small duct type ICC is ICC with ductal plate malformation-like pattern. DPM-like pattern ICC is characterized by a dilated cystic lumens with polypoid protrusions. The post-operative prognosis of this kind of ICC is relatively rare. Their recurrence and metastasis are also very rare. The mixed type of ICC we listed here is a kind of tumor that contains multiple ICC components, which we think may reflect the different biological behaviors and the clinical prognosis. For example, it's reported that the more the proportion of CLC components, the better the post-operative prognosis. So we recommended describing the proportion of each tumor component in the pathological report. Based on literature reports and our own experience, we suggested using S100P plus MUC5AC plus CRP and encountering as the 4-marker immunohistochemical panel for ICC subclassification. WHO classification recommended using the term of intrahepatic cholangiocarcinoma instead of cholangiocellular carcinoma and cholangiocellular carcinoma. At present, the diagnostic terminology of ICC is not fully consistent. Some scholars, including UICC TNM staging system, prefer to use cholangiocellular carcinoma to prefer CLC and ICC. Actually, we agree with WHO's suggestion and recommended using intrahepatic cholangiocarcinoma as the normative pathological diagnostic term. Specific and defined biomarkers of targeted therapy and immunotherapy for ICC have been recommended in both NCCN and Chinese Society of Clinical Oncology, CSCO, guidelines for biliary tract cancers. Therefore, we listed here all the biomarkers, targeted drugs, and the detection methods to provide the basis for molecular pathological detection. Clearly, it's important to make an accurate subtype diagnosis of ICC. This slide shows a flowchart of ICC pathological diagnosis, which we recommended in our consensus. Finally, I would like to mention that before this ICC consensus, we have a guideline for the pathological diagnosis of HCC. The two key points of which include a 7-point sampling protocol for surgical resected HCC growth specimens, which is correlated with detection rates of macrovascular invasion, and a macrovascular invasion grading system, which is correlated with post-operative OS and RFS. Taking the guidelines of HCC and ICC together, we expect that we may improve our overall homogeneity of pathological diagnosis of primary liver cancer in China. That's all. Thank you very much for your attention.
Dr. Kong, thank you very, very much for that very interesting talk. I'm sure it will generate much discussion in the chat. So thank you again. Could you stop sharing your screen? That would be helpful. So great. I want to introduce our next speaker. So our next speaker will be Dr. Ihab Kamel. Dr. Kamel is actually a good friend, and I would say one of the best hepatoradiologists in the world. I consider whatever this individual says to be gold. Dr. Kamel is the vice chair of MRI operations at Johns Hopkins University, where he has a very busy clinical practice, but then also is a leader in translational work around novel imaging of primary and secondary tumors of the liver. So we're incredibly lucky to have Ihab with us today to talk about radiologic imaging of ICC. So Ihab, I'll turn things over to you, my friend.
Well, thank you very much for the introduction and your kind words. Can you see my slides?
Yes, we can.
Okay, great. Thank you again, Tim, for the introduction and your kind words. It's a pleasure and an honor to be here. And I also want to thank Dr. Ramandori for the invitation here and a great lecture series. And I'm super excited to be here and attend more of the lectures as well. So without further ado, I was asked to talk about radiologic imaging of intrahepatic cholangiocarcinoma. And as Dr. Pollack alluded to, it's something that's really dear to our heart, and we partner together and we continue to do so to have better imaging characteristics and better identification of these tumors, to assist in better management and better response to therapy assessment as well. So here's an outline of what I will be talking about. Briefly, a couple of slides about the introduction. about presentation, and Dr. Washington did a great job about risk factors, so I'm not going to get into that too much. We'll talk about the classification of cholangiocarcinomas, but then my main focus will be imaging findings, ultrasound, CT, and the role of volumetrics in CT, MRI, MRCP, and volumetrics as well. I will touch upon the role of hepatobiliary contrast agents, then talk about PET, cholangiocarcinoma. Definitely, oftentimes we get PET for staging and for assessing, for follow-up to assess for recurrence as well. Something that Dr. Kong alluded to, which is the mixed type or the hybrid HCC cholangio. And I'm going to share with you a couple of slides from the revised LIRADS about LIRADS M, which is the malignant category, oftentimes may include cholangio. Then I'll share with you our response assessment criteria, the limitation of current approach, including the conventional criteria, RECIST, M-RECIST, and ESOL, and what we currently utilize to assess response using functional MRI. Briefly, as was mentioned by Dr. Washington, cholangiocarcinoma is the second most common primary hepatic tumor. The incidence is about 2 in 100,000, certainly more in Asia, and about 3,000 cases, new cases in the United States annually. Typically in the older 50 to 70 old age group, slightly more predominant in males than in females. And it arises from the intrahepatic bile ducts or extrahepatic bile duct epithelium. Going to the symptoms, unfortunately, the intrahepatic type is often incidental, but if there are evidence of obstruction, oftentimes there is all the imaging, the clinical symptoms of biliary obstruction, including jaundice, itching, clay-colored stools, weight loss, right upper quadrant pain and weakness as well. Risk factors, again, were mentioned, so I'm not going to get into that, but highlighting cirrhosis. Cirrhosis, we're seeing more and recognizing more cholangiocarcinoma in the background, cirrhotic liver, than what we have anticipated maybe 5-10 years ago. Certainly congenital malformations, as was mentioned, chronic inflammation, infection, and perhaps the most established is the primary sclerosing cholangitis. And this is one example of a PSC where you can see the beaded appearance, the irregularity of the ducts, and you can see here on MRCP as well as ERCP, the manifestations of PSC. Oftentimes these patients are at risk of developing cholangiocarcinoma. Here's a clinical conundrum. When we are faced with the imaging or to rule out cholangiocarcinoma, oftentimes these happen in a background abnormal liver, such as PSC or cirrhosis. So it becomes a little bit more challenging to detect the mass. I will talk about LIRADS and its role because what we have thought to be HCC in the past oftentimes ends up being a mixed type or a cholangiocarcinoma. So I'll share an example with you. Also, it's difficult to distinguish a benign from a malignant stricture by imaging alone or by serum biomarkers or biochemically. So oftentimes we use CEA and CA19-9 with high sensitivity and specificity. And when these values or biomarkers are elevated, oftentimes the disease is more advanced. We talked about the classification and our focus on the intrahepatic type, which is usually the more common type. It is often peripheral within the hepatic parenchyma. It could be exophatic or polypoid, and sometimes infiltrative as well. When it's more central, it's more Klatskin type, and it could be purely ductal, periductal, or presenting as ductal, wall thickening, and the stricture, and that's beyond the scope of this presentation. So starting with ultrasound, oftentimes that's the primary imaging modality, right upper quadrant pain, or in a cirrhotic patient screening for mass. So oftentimes we see a poorly defined mass with or without ductal dilatation. So we look for the ductal dilatation, and oftentimes the epicenter or these ducts point us to where the possible mass is. Oftentimes the mass is poorly defined, slightly of mixed echogenicity. Oftentimes there is portal venous invasion as well. More commonly, we use ultrasound to guide biopsy if biopsy is indicated. This is an example of a right upper quadrant ultrasound, and you can see here the dilated ducts, mildly dilated, and then you go a little bit more centrally and you see a poorly defined mixed echogenicity mass in the left lobe of the liver. So this is a very large mass leading to ductal dilatation. Is this going to be diagnostic of cholangio? Usually not. There will be a second imaging, typically CT. So CT delineates the site and cause of biliary dilatation or obstruction. We typically do it as a dual phase, meaning arterial and venous phase, because we want to assess the vasculature. We may end up doing volumetrics if there's a potential resection. Infiltrative tumors are homogeneous with low attenuation, and the enhancement is typically peripheral. So this is something very important because of the predominant fibrous tissue. It starts peripheral and it persists for a long time. This is very different from HCC and oftentimes have a target or a targetoid appearance. And I'll show you some example. And capsular retraction is one of the things that we look for because it's very, when we see that, we know we're dealing with a cholangiocarcinoma. This is a very nice example where you can see the rim enhancement. If this is an HCC, it will be uniformly or mixed hypervascularity. When we see a rim, when we see capsular retraction, and you can see here the heterogeneity and the persistence of enhancement, this is not washing out. This is continuing to fill in. And in a heterogeneous pattern, this was a case of an intrahepatic cholangiocarcinoma. We look for vascular involvement. You can see here the amputated anterior right portal vein, something that we often look for to make sure that there's no vascular involvement. Here's another example where you can see the ducts pointing to a more hilar mass, and this is part of the mass. We look more superiorly. You can see a large infiltrative mass, again, poorly vascular with a little bit of a rim around it. This is very concerning for a cholangiocarcinoma. And you can see the amputated biliary tree here. I think there's some background noise. Anyway, here's another example of a CT of intrahepatic cholangio. You can see a large mass with capsular retraction, with ductal dilatation, oftentimes with large adenopathy. We oftentimes may mistake this for an HCC because you end up seeing evidence of portal hypertension, but certainly this background liver is non-cirrhotic. The portal hypertension is because of the portal vein involvement here and resulted in splenomegaly and ascites. So sometimes distinguishing between an HCC and cholangiocarcinoma can be a challenge. Here's another example of an intrahepatic cholangio, poorly vascularized, and you can see the ducts radiating from this area, and you can see the distal ductal dilatation. Looking at the portal vein as well, you can see here that the narrowing and the caliber change of the right portal vein, and you can see the dilated ducts in the coronal plane. This was an intrahepatic cholangio. What about MRI and MRCP? Definitely is great for defining the tumor extent. So everything that CT would show will be also apparent on MRI with additional features. You will see the bile ducts better. It's non-invasive, so it's better than an ERCP, no ionizing radiation. And it delineates the vascular involvement similar to what you would get with CT. We can often do volumetrics if needed as well. Infiltrative cholangiocarcinoma is poorly defined with low signal on T1 and high signal on T2, a little bit of edema there. And oftentimes we may see the mass extending along the ducts, causing ductal dilatation. Here's one example where there's a very large infiltrative mass. You can see here on T1 unenhanced, it is poorly defined and it is low in signal, and you can get a hint of some dilated ducts more distally. In the arterial phase, there is a rim of enhancement, very heterogeneous enhancement. On the delayed 3-minute phase, you can continue to see the enhancement gradually filling in with areas of central necrosis. So the combination of rim enhancement, some capsular retraction, dilated ducts with continued fill-in would point us to the diagnosis of cholangiocarcinoma. Oftentimes it metastasizes. This was one extreme where you can see a lot of liver lesions here with innumerable hepatic metastasis. This was biopsy, and this was all cholangiocarcinoma metastatic within the hepatic parenchyma. Role of Avast or the hepatocellular contrast agents. These are contrast agents that we use to define and better assess tumor burden, because cholangiocarcinoma does not contain functioning hepatocytes. So on the delayed phase, the liver would be very bright, and that's typically around 20 minutes. And if there is a mass that is non-enhancing on the delayed phase, in addition to your T2, the capsular retraction, you can confirm that this is a non-hepatocellular tumor. And in the setting of cholangiocarcinoma, this is the primary mass. But if you notice here, there was a subtle lesion with no uptake at 20 minutes, moving more inferiorly, subtle T2, subtle enhancement, no uptake on EFS. So you start to see all these intrahepatic metastases that would be valuable to know of, especially if the patient is a surgical candidate. So hepatobiliary contrast is very useful in the setting of staging of cholangiocarcinoma. If there's any potential resection or for vascular mapping, we can use, here is a CTA venogram, and you can get the same information on MR. You can map the hepatic artery, you can map the portal vein, the hepatic veins. We can do segmental calculations and predict future liver remnant as needed in a potentially surgical cases. Now, PET-CT is very important because it has high sensitivity in nodular cholangiocarcinoma, not as high for the infiltrative type. So anytime we suspect cholangiocarcinoma, we may end up getting a PET or a PET-CT for better staging. Now, there are subfolds positive, especially in the setting of PSC, primary sclerosing cholangitis, or if there's any inflammation or inflammatory changes, especially after biliary manipulation. Oftentimes, these patients come after the initial diagnosis with a stent in place. So the question is the uptake around the stent from the tumor, or is it related to the recent stent placement? Here are some examples of a positive PET, and you can see the large mass in the gallbladder fossa, also invading the gallbladder with a few other foci, better seen on PET here in the left lobe of the liver. Also, PET will pick up lymph nodes, and if we have any concern by imaging and they're PET positive, they're usually more suspicious. There's another mass, large mass in the dome of the liver, and you can see here the heterogeneity on CT and the very intense uptake on PET. This is another example where you can see the ducts dilated in the left lobe and segments for A and B, and some segment 8 as well. Very subtle lesion here on CT, subtle on T2 MR, and then you do volume rendering, and you see these ducts going or radiating from a mass that is best seen on MR arterial phase here with surrounding perfusion change, REM enhancement, very positive uptake on PET. This is all consistent with a cholangiocarcinoma. Just a few words about LIRADS, because this is very important. This is a cirrhotic liver, and you can see here a hypervascular lesion not washing out, but has a target appearance. And that target appearance is not typical for hepatocellular carcinoma. When we got the MR and diffusion is a very water sensitive sequence. Again, you see here the subtle T2 rim around the lesion. Anytime we see this, we need to, this is not a LIRADS 5, this is a LIRADS M, and more we're seeing the mixed type, as in this case, this was a hepatocellular carcinoma with a cholangiocarcinoma, different outcome, different management. That's why it's important to realize that if it's not a typical LIRADS M, 5, that we categorize as LIRADS M, and oftentimes we need a biopsy. And I'm constantly reminded by the revised LIRADS group that the risk of HCC is 33% in LRM, 66% could be other malignancy, typically either pure cholangio or a mixed cholangio and HCC. And again, here it shows that we are taking that more into consideration now because these tumors have different biologic behavior and different outcome. Briefly talking about treatment and assessing response, whether it's chemotherapy or whether it is chemoembolization or more recently immunotherapy, imaging is often required to assess response. And certainly can use biomarkers and lab values to see if CA19-9, for example, is going down after therapy. That usually indicates a favorable response. But oftentimes we rely on imaging. And this is one example where there was a lot of vascularity. And you can see the lipidal deposition post-angio here. And this was a treated lesion. Now, the question is, how do we assess response? As many of you know already, oftentimes these tumors are poorly defined, they're irregular in shape, and they don't shrink post-treatment. They may become less vascular. So we rely on RECIST, but RECIST may not show shrinkage. If you rely on mRECIST, in our experience, it's very difficult to determine where the residual enhancement is, especially in something that is rim enhancing or irregularly enhancing, the same challenges with ESOL. So our team, partnering with Dr. Pollack at Hopkins, we published one of the very first articles back in 2012, looking at how volumetric MR acquisition, assessing changes within the entire tumor volume by apparent diffusion coefficient, which is routinely acquired in MRI, we were able to better stratify responders from non-responders by looking at apparent diffusion coefficient. Most of these tumors in 29 patients were in the stable group by RECIST, and that's no surprise. They remain stable in size. ESOL was not assessed in about a third of them. Again, that's no surprise, but 21 of the 29 patients achieved partial response based on changes in motion of motor water molecules within the MRI studies. We followed this by a larger data set, 94 patients, looking at unresectable intrahepatic cholangiocarcinoma and looking at survival assessment and prediction using viable tumor burden, which is percent of tumor volume to the liver, as well as the ADC, the apparent diffusion coefficient. And we were able to better stratify responders from non-responders based on tumor burden and changes in ADC. Typically, if the tumor is very viable at baseline and small burden, these are more likely to respond to chemoembolization as opposed to a very large tumor burden and already necrotic tumor, unlikely to respond to chemoembolization because it's already necrotic with poor vascularity, and the large burden will negatively impact survival. So this is what we currently use today. We measure tumor volume, we measure the ADC and try to predict response. So this was a quick overview looking at the role of imaging using ultrasound. Typically, it's a large mass with ductal dilatation. We often use it to guide biopsy. CT is used for staging, looking for vascular involvement, looking for volumetric assessment as well. MRI and MRCP, in addition to staging and vascular involvement, we can assess volumetrics. PET is essential, and we always get it to stage patients at presentation and look for any recurrence. Keep an eye on LIRADS and be very aware of the need to biopsy if this is not a LIRADS 5, it's a LIRADS M, because it could be a cholangiocarcinoma or a mixed type, not a hepatocellular carcinoma. We briefly talked about response assessment and the limitation of the current criteria, and we currently use volumetric criteria that include diffusion and tumor burden to better predict tumor response. And with that, thank you for your attention.
Thank you very much, Dr. Kamel, for really what is a tour de force of reviewing state-of-the-art imaging for intrahepatic cholangiocarcinoma. And I have some questions for you, which I'll ask after I give my talk. So we will proceed with the next talk, which will be my own. And I'm going to be talking about the surgical management of intrahepatic cholangiocarcinoma. And as been noted, as surgeons, most of the time, at least in my practice, this is what happens. You know, somebody may, have some vague symptoms and a CAT scan is obtained or an MRI is obtained, and then there's a mass in the liver. And then the question becomes, what is the mass? Is it a primary tumor of the liver? Is it a secondary tumor metastatic from another site? Typically what happens is when someone sees a mass in the liver, they stick a needle into it. And then the question becomes, when the diagnosis is adenocarcinoma, again, is it a primary or secondary? And we heard from our previous speaker about the different immunohistochemical tests that can be done on the specimen to help elucidate whether this is truly an intrahepatic cholangiocarcinoma. Some of the things that will be looked for are biliary dysplasia. And then we heard about the battery of immunohistochemical stains that will be done on the specimen to rule out other potential primary tumors such as lung or colon or even pancreas, and then a battery of IHC stains that will help rule in a primary that is consistent with biliary epithelium. And typically, our hepatopathologists are now pretty good today, and they'll tell you that this is very likely to be an intrahepatic cholangiocarcinoma or something from a biliary origin. Despite that, I think it is important to make sure that we rule out other etiologies of a mass in the liver with a histological diagnosis of adenocarcinoma. We do routinely send off serum biomarkers, but it's important to note that while these are specific, they're not incredibly sensitive. There will be a subset of patients that can have hepatocellular carcinoma or intrahepatic cholangiocarcinoma and have completely normal AFP, CA19-9, or CEA. It's unlikely, however, if these markers are extremely elevated, that it would be a false positive. So it is helpful to obtain these serum tumor markers. I also think it's important then, as a surgeon, when you see these patients, to rule out other primary tumors. So if I have a female patient, I'll make sure that they're up to date on their mammogram or gynecologic exams. And then I'll selectively use upper and lower endoscopy. I've definitely had patients referred to me for intrahepatic cholangiocarcinoma who ended up having a colon cancer. I remember another patient who ended up having a gastric cancer that was metastatic to the liver. So it is important that one does fully rule out other primary tumors that could be masquerading as a primary intrahepatic cholangiocarcinoma, but indeed is representative of metastatic disease. As we heard from Dr. Kamel, really the workhorse of working up this disease as surgeons is cross-sectional imaging, CT and MRI. And then also, as touched upon, I tend to use PET fairly frequently in a population of patients who I'm suspecting intrahepatic cholangiocarcinoma, and perhaps ironically, perhaps even more than I would for patients with colorectal liver metastasis. And I'll explain my reason for that as a surgeon later on. We heard from Dr. Kamel that there are different morphologic subtypes of intrahepatic cholangiocarcinoma. And as surgeons, it's important for us to be familiar with the different morphologic subtypes, whether it be intrahepatic, mass forming, periductal, or interductal growth pattern. And you can see here the different morphologic features of these tumors, with mass forming, having this classic capsular retraction and a hypodense lesion, the periductal infiltrating, having these dilated duct with the enhancing rim of the duct, and then the intraductal growth pattern having this kind of ductatasia. When we talk about intrahepatic cholangiocarcinoma, however, we're mostly talking about mass-forming lesions. If we look from data from the Liver Cancer Study Group of Japan, or even data from the United States or other areas, about 80% of these intrahepatic cholangiocarcinomas will be mass-forming. And it's important as surgeons to have a certain, ease or familiarity with different modalities of imaging. It's been my experience that many surgeons are much more comfortable with CT than they are with MRI. But at least in my practice, I typically favor MRI over CT. And again, as Dr. Kamel alluded to, MRI is fairly sensitive and specific for differentiating intrahepatic cholangiocarcinoma from hepatocellular carcinoma, whereas hepatocellular carcinoma tends to be a soft tumor in a hard liver if it's cirrhotic. These intrahepatic cholangiocarcinomas tend to be very fibrotic tumors, so they only tend to enhance usually in the later phases of the scan. And then you can see here in panel B, they have this peritumoral ductal dilatation. So even though I rely heavily on my colleagues such as Dr. Kamel, I think as surgeons, we need to obviously look at our own scans and have some familiarity. And in looking at a scan like this, we as surgeons should have a high suspicion for intrahepatic cholangiocarcinoma. And then again, on this MRI, you can kind of see some of the pathognomonic features with the capsular retraction, this late enhancement, central necrosis, and then peritumoral ductal dilatation. As was noted again by Dr. Kamel, these lesions tend to be FDG avid. And so I tend to use PET for a number of reasons. One is that sometimes you can identify an occult primary tumor that you didn't suspect on a PET scan. And then you can also sometimes identify occult metastatic disease. And Dr. Kamel showed that image where a patient had intrahepatic metastasis in the left hemiliver that were much better identified on the PET scan than they were on the cross-sectional imaging. And then you also may find evidence of FDG avid disease in the nodal basins, either in station 12 in the perihilar area or even beyond station 12. And at least in my practice, if I identify nodal disease in the preoperative setting, I'm much more inclined to treat that patient with preoperative neoadjuvant therapy rather than take them directly to the operating room, because as I'll show, the data would suggest that patients with preoperative nodal metastasis have a very high incidence of recurrence and even a very high incidence of very early recurrence within the first 6 to 12 months after surgical resection. So about 15 or maybe even 20 years ago, we put together the Intrahepatic International Consortium, which is now made up, I believe, of more flags than this. I need to update the flags, but about 18 to 20 centers from every continent in the world, except from Antarctica. We've been able to collaborate and collect data on well over 1,000 patients with resected intrahepatic cholangiocarcinoma. And for surgeons who take care of patients with this disease, we know this can be a technically challenging disease to treat surgically. Many of these patients, as we heard from Dr. Washington, present with vague symptoms or asymptomatic. And so by the time their disease is diagnosed, the tumor can be quite large and also be located in challenging situations. This is a patient of mine who has a relatively large lesion located in the central portion of the liver that's involving segment 4B, but also segment 5. You can see that it is involving the anterior sectoral branch of the right portal vein and abutting the posterior sectoral branch of the portal vein. So this is a large tumor in an inconvenient location and really would necessitate an extended right hemihepatectomy, which is exactly what we did. And you can see this picture after the specimen has been removed at the base of the umbilical fissure, segments 2 and 3 of the bile ducts, because we had to perform an extrahepatic biliary resection also in order to completely extirpate this tumor. And then you can see the portal vein and the hepatic artery. But even despite these very large operations, the margins that we're able to achieve at the time of surgical resection can be somewhat close, and it can be difficult to achieve a wide negative surgical margin. So here's another patient of mine. This is a patient who presented with the lesion in the left hemiliver. Here are some representative cross-sectional images. What you may or may not be able to appreciate is that we can see the vena cava up here to the far left in the right hepatic vein, but the middle trunk of the left hepatic vein and the middle vein could not be visualized, and there was some concern that there was involvement of the common trunk up to the vena cava, and it was unclear whether I could gain purchase, if you will, on that common trunk. And because of the extent of this disease and some satellite ptosis around the disease and a CA19-9 that was in the range of about 500, I elected to treat this patient initially with some systemic therapy, and then following systemic therapy, actually treated this patient with Y90 to the left hemiliver. After that, I took the patient to the operating room and performed a left hepatectomy, or a little bit of an extended left hepatectomy, and was able to remove the entire tumor. We were able to get above the left common trunk and divide the common trunk right on the vena cava. And actually, this patient is alive about 2 years later, free of disease, doing well. Interestingly, on the explant, there was about 60% viability of the tumor, despite having been treated with preoperative chemotherapy in the Y90, which I thought was interesting, and perhaps we can discuss later. This is a different patient that I treated. This is a patient who presented with a very large tumor in the right hemiliver, who actually was jaundiced, presented with an elevated bilirubin. You can see that the right hemiliver is severely atrophic, with some compensatory hypertrophy of the left hemiliver. You can also see a biliary stent that we placed. And then perhaps most concerning is that you can actually see some ascites outside of the liver. This patient, you can see on the coronal images, was similarly treated with preoperative chemotherapy. He had an extremely high CA19-9 of over 100,000, but had a good response to chemotherapy. His CA19-9 came down markedly. It didn't normalize. I think it was below 1,000, and most of his ascites resolved. I don't know if Dr. Rorachari treated this patient or not. I can't remember, but maybe Samit can comment later. And rightly or wrongly, I ended up taking this patient to the operating room and performed a right hemihepatectomy on this patient. But unfortunately, this patient recurred within a year and then has subsequently succumbed to his recurrent disease and died. So I think these cases kind of highlight some of the technical challenges of big operations, extended right, extended left, but also some of the difficult clinical decisions that we face as surgeons about who to operate on, who not to operate on, you know, treating these patients with preoperative chemotherapy, preoperative regional therapy like Y90, and then making decisions about whether we should take them to the operating room after preoperative therapy. At the time of the surgery, you know, one thing that is a big concern is margin status, right? As liver surgeons, we love to talk about anatomic versus non-anatomic resection. I think most of us agree that there's fairly robust data from China and Japan and other places that for hepatocellular carcinoma, that the tumor tracks along the portal triads, and that there may be a survival benefit associated with a truly anatomic resection. At least data from our group in examining over 1,000 patients who have undergone resection, there did not seem to be a survival benefit versus anatomic versus non-anatomic resection. So I do not believe that we must do anatomic resections for patients with intrahepatic cholangiocarcinoma. However, as these data demonstrate in a separate paper, there clearly is a benefit with regards to overall and recurrence-free survival in obtaining a negative margin, and one should try to achieve at least a 5 millimeter and at least ideally a 10 millimeter negative margin at the time of surgery. Sometimes in order to obtain this negative margin, we need to do a vascular resection. And these data demonstrate that if we need to do a vascular resection, one should proceed with doing that, because long-term patients can have the same overall outcomes as patients who did not have a vascular resection. However, one must note that there is increased perioperative morbidity and mortality, which can be as high as 8 to 10% following complex vascular resections and reconstructions. And therefore, these procedures should only be done at expert centers that are high of volume. One thing that is important is to recognize how we stage intrahepatic cholangiocarcinoma. And it's interesting to note that the first 6 editions of the AJCC UICC staging manual had no staging system for intrahepatic cholangiocarcinoma, and simply noted in like a sentence that it should be staged the same as hepatocellular carcinoma, which really makes no sense because these are 2 different diseases. There have been 2 Japanese groups who had proposed distinct staging systems for intrahepatic cholangiocarcinoma, but these staging systems really weren't robust, did not reach statistical significance, and never really caught on worldwide. And now, over a decade ago, working with Dr. Hari Nathan, who's now attending at University of Michigan, our group, based on some data that we published, proposed a new simplified staging system for intrahepatic cholangiocarcinoma that was based on the presence of multifocal disease and also the presence or absence of vascular invasion. And one of the things I'm probably most proud about is that our research was recognized by the AJCC UICC staging manual. It was actually incorporated into the 7th edition. And now, since the 7th edition and 8th edition, there is a staging system for intrahepatic cholangiocarcinoma. And as surgeons, we need to be aware of this staging system. And here I note that the T1 classification is based on size, with T1A being less than or equal to 5 centimeters, T1B being greater than 5 centimeters, and then T2 reflecting whether there is vascular invasion or not, or whether the disease is unifocal or multifocal. And this staging system has been validated by our group as well as many other surgical groups throughout the world, and really should be the standard of care of how we pathologically stage patients following hepatic resection. One other thing that we think is interesting is that our group and others have proposing this notion of a tumor burden score, which is a single composite score that takes into account the overall number and size of the lesions in the liver to derive a single composite score with regards to the overall burden of disease in the liver. And interesting, and perhaps not surprisingly, is that the overall burden of disease is strongly associated with overall survival. And you can see here that patients who have a high tumor burden score, their 5-year survival is only 17%, and their recurrence-free survival is only 7%. So we would argue that perhaps tools like this may help us as surgeons better identify who should be treated with preoperative systemic therapy or some other modality. These patients are unlikely to benefit long-term from surgical resection. So similar to pancreatic adenocarcinoma in that paradigm, where we've moved to using preoperative therapy to better define biology, this may suggest that in this subset of patients, we should be adopting that approach. Another thing that we've done is use machine learning and artificial intelligence to try to identify different subtypes of intrahepatic cholangiocarcinoma. And using that based on size, CA19-9, and the lymphocyte to neutrophil ratio, you can see here that machine learning kind of cohorted 3 distinct subsets of patients that we've classified as clusters 1, 2, and 3, being either common, proliferative, or inflammatory intrahepatic cholangiocarcinoma. And again, you can see here that patients who have inflammatory intrahepatic cholangiocarcinoma do particularly poorly. And again, perhaps this subset of patients should be treated with preoperative chemotherapy before going to surgery. We've talked a lot about surgical margin and surgical resection of the hepatic parenchyma, but the other thing that is important is whether we should be doing a lymphadenectomy as surgeons at the time of surgery. And these data would suggest that only about half of patients undergo a lymphadenectomy. But in those patients who do undergo a lymphadenectomy, the overall incidence is about 30%. And even if we presume the best case scenario that everyone who did not undergo lymphadenectomy, NX is N0, the incidence would still be in the range of about 20%. So we know that the underlying incidence of lymph node disease is 20 to 30%. We also know that our group and others have tried to identify using machine learning, radiomics, and other means, can we identify which patients are most likely to have lymph nodes at the time of surgery so we can selectively use lymphadenectomy? And to date, the answer is no. These predictive tools are relatively poor, and we know that even patients with T1A disease, the incidence of lymph node metastasis is still in the range of about 10 to 15%. And therefore, we would advocate for routine lymphadenectomy at the time of surgery. Why? Because we do lymphadenectomy for every other gastrointestinal cancer, colon cancer, rectal cancer, pancreatic cancer, gallbladder cancer, because we know lymph node status is extremely prognostically important, as can be seen here. And we would argue that if you do not gather the information on lymph node status, you might as well not stage the patient at all. Because once patients have N1 disease, what's driving their prognosis is not the T category factors like vascular invasion or single or multifocal disease. It's really the fact that they have metastatic disease in their nodal basin. So as surgeons, it's important to do a lymphadenectomy, and it's also important to know which lymph node stations need to be dissected at the time of surgery. And these, again, are some data from the Liver Cancer Study Group of Japan showing that there is some laterality to the drainage of the liver. So when a tumor is located in the right hemiliver, groups 1 and 2 should be dissected and evaluated. So not only station 12, which is the hepatoduodenal ligament, but also 7, 8, 9, and 13. But when the tumor is located in the left hemiliver, the surgeon should also evaluate lymph node stations 1 and 3 around the celiac artery and the periesophageal area, as this is another common location of lymphatic drainage for tumors in the left hemiliver. And it's important to dissect these various nodal basins because, as this paper that we published in Annals of Surgery showed, that in patients who have nodal metastases beyond lymph node 12, that their prognosis is significantly worse, and metastasis in nodal stations beyond 12 likely represent second echelon disease with the worst prognosis. Ideally, we would like to harvest 6 lymph nodes at the time of surgery, as this is the recommendation in the AJCC UICC manual. However, unfortunately, if you look at population data, you will note that only about 50% of patients even have 1 lymph node evaluated, and only about 15% of patients reach the recommended threshold of 6 lymph nodes. And despite these large liver operations and these, clearance of the nodal basins, the outcomes following resection remain poor. And in this paper that we published in Cancer, the overall probability of a true cure at 10 years remains very low at only about 10%. And the reason for this is that patients recur. And if I look at this survival curve, it reminds me a little bit of the survival curve after a Whipple for pancreatic adenocarcinoma. And we know that similar to pancreatic cancer, patients with intrahepatic cholangiocarcinoma recur often and they recur early. If you look at these data, 55% of patients experience a recurrence less than 2 years following surgical resection. And the other thing that's interesting to note that about 50% of patients had an extrahepatic site of recurrence as a component of their failure. And in this paper that we just published in JAMA Surgery a couple years ago, we noted that actually 1 in 5 patients will actually recur within 6 months following surgery, which I think is very sobering. Do a large operation on a patient, take out half their liver, 3/4 of their liver, and then 1 in 5 are recurring after that type of operation. So we have made available an online calculator that can help estimate the risk of very early recurrence. And we believe tools like this will help inform us about which patients are going to be at prohibitively high risk of recurrence, specifically those patients with multiple lesions, those patients with preoperative lymph node metastases. And then we can better integrate not only adjuvant therapy, but more effective systemic and targeted therapy in the preoperative setting, which we're going to hear about from Dr. Aurora Chowdhury after the break. So I want to conclude. Hopefully I've highlighted that intrahepatic cholangiocarcinoma is a serious disease with a high case fatality. As surgeons, we should strive for a margin negative resection. I firmly believe that routine lymphadenectomy should be performed in all patients, and that as surgeons, we need to be a little bit more selective, perhaps, in who we're taking to the operating room right away, as perhaps certain subgroups of patients, in particular those with a high tumor burden score or inflammatory proliferase subtypes, may benefit from preoperative therapy to sort out their biology before taking them for operative resection. And therefore, we really need to adopt a multimodality approach if we hope to increase and improve the overall survival and outcomes of these patients. So with that, I'll conclude. I will stop sharing my slides, and perhaps at this time, I can ask our speakers from this session to turn on their cameras, and we can use the next 10 minutes or so to have a discussion before our break at 11:05. Thank you. So great. So I ask if people have questions, maybe you raise your virtual hand, and or enter comments into the chat room. So Professor Ramadori is going to kick us off. Giuliano, I think you're on mute.
Yeah, thank you very much for the great talks. Thank you, everybody. We really saw also beautiful pictures, and I want to ask Team you now. You saw that PET is a good diagnostic technique. Do you have data on PET positive lymph nodes before you operate?
So I don't have data on like the independent value of like PET. Like PET is associated with the worst prognosis. I mean, they're collinear. So if your lymph nodes are positive on PET, then you're usually, you have lymph node metastasis, and lymph node metastasis are associated with the worst prognosis, right? So that's my line of logic. I don't know if Dr. Kamel can comment on if there's like a false positive with regards to like nodal disease on PET. But again, in my practice, if the PET scan lights up with lymph node metastasis, I am more inclined to treat them preoperatively with chemotherapy because I know they will have a worse prognosis. I don't know, Ehab, can you comment?
Yeah, I agree. I think that typically we look for suspicious adenopathy, not just by size, but on cross-sectional imaging, CT or MR. If the lymph node is more rounded rather than flat, if it loses its fatty hilum, and if it becomes centrally necrotic with intense enhancement, these are very suspicious features. We typically will get PET, and PET often confirms that there's FDG uptake. If we have any questions and they are accessible to biopsy, we may biopsy these. But as was mentioned by Dr. Pollack, if the lymph nodes are suspicious and they are PET avid, I don't see a lot of reactive adenopathy in the setting of cholangiocarcinoma. Maybe in the setting of hepatitis and HCC, oftentimes we see these portacaval lymph nodes that are reactive, but significantly less likely in the setting of cholangiocarcinoma.
Thank you, Dr. Kamel. I was going to ask Dr. Washington a question. So, Dr. Washington, you mentioned different risk factors for intrahepatic cholangiocarcinoma. I was wondering if you could comment just a little bit more on, like, is there any role for screening in high-risk populations? And then also wanted to just ask you a little bit if you could comment on, maybe the different phenotypes and genotypes of cholangiocarcinoma based on the etiology of the disease, whether it be kind of like sporadic or associated with hepatolithiasis or, liver flukes or anything like that. Is there some heterogeneity in how we should think about cholangiocarcinoma geographically or based on etiology?
Sure. I think to answer your first question about screening, obviously, like I mentioned, most of the patients who are being quote screened are usually being screened because there's a concern for HCC. Since we don't have really great data on what specific disease processes increase your risk of developing ICC specifically, we tend to screen patients and we tend to surveil, I guess, patients who have risk factors for HCC, like your cirrhotics and those who have non-alcoholic fatty liver disease and that sort of thing. So that's one of the benefits of doing more population-based studies that specifically focus on intrahepatic cholangiocarcinoma, because then it will allow us to identify those factors that we can create a subset of patients that are at a higher risk of developing intrahepatic cholangiocarcinoma that may or may not be related to a diagnosis of cirrhosis or that sort of thing. And of course, like I mentioned before, the choledochal cyst patients, the PSC patients, we know those as high risk. And so those patients are being monitored once they're diagnosed with those highly inflammatory type biliary diseases. But other factors, like I mentioned, such as diabetes or obesity, those things are still kind of a question because obesity is so prevalent, particularly in the United States. It's hard to pull the patients out that are at the highest risk in order to surveil them. And of course, cost becomes an issue, which is a huge thing here in the United States as far as surveillance and preventative measures. Is that we have to look at the things that are going to give us really the most bang for our buck. And so identifying those patient groups that are at highest risk are very, very important. And that's the reason why these epidemiologic studies are so necessary.
Thank you, Dr. Washington. I have a question for Professor Amadori. Yeah, please.
To the talk of Kimberly. I mean, I appreciate very much that you mentioned tobacco. I mean, smoke as a risk factor, right? Did I get the message? I think this is one of the first papers I read that, and I think it's very important. You would ask, how does it happen? How does tobacco influence development of even cholangiocarcinoma? It's maybe important for your team, if you have patients who smoke, then tell them to stop it, even if after you have operated them, because there's some kind of growth factors may be induced by smoking, right? Can it be? So the next.
I think with tobacco, the thing about it is we don't, outside of lung cancer, I don't think we really know the pathophysiology that causes the development of any cancer in relation to smoking. But for whatever reason, patients who have a chronic history of smoking are at risk of every malignancy. There's very few where it's not in some way correlated. Now, and is that because tobacco use is also associated with other things that are at higher risk? I don't know. But this is, again, the reason why these sorts of studies are so important, because we need to flesh out what is it about tobacco that makes you at a higher risk of developing all types of malignancies. And intrahepatic cholangiocarcinoma is not unlike the rest.
Thank you. I had a question for Dr. Kamel. Dr. Kong, I have a question for you also. If you're able to turn your camera on, I'll ask it after I ask Dr. Kamel. So Ehab, I was just going to ask you, you talked a lot about, assessing response, and we're going to hear from Samik a little bit later, and also from Bas about, systemic therapy, local regional therapy. Is there any role for, CT in that area, or, you largely highlighted MR, and I was wondering, we frequently have this discussion, especially from a global perspective, about use of CT versus MR, kind of institutional dependent and provider dependent. I was just wondering if you could comment a little bit more around CT versus MRI for primary diagnosis, but then also, I think more importantly, as we're beginning to use more systemic and local regional therapies, what's your kind of your take on that?
Great question, and oftentimes we struggle with that. Certainly, CT continues to be a lot more available than MR, and fewer contraindications, especially in elderly population, if they have a device, if they have a pacemaker, and so forth. And it definitely is a longer study. But on the other hand, MR has made significant advantages in having faster acquisitions, wider bore, and also the contrast agents now are safer than before, even in patients with impaired kidney function. So there are pros and cons. Certainly CT continues to be the primary modality. I think that there are innovations in both CT and MR, but and these in the CT world include dual energy, for example. But the criteria for assessing response continue to be lagging behind. In other words, your conventional criteria are still based on tumor size or maybe tumor enhancement. To make it simplistic, the challenge with that is that you end up using very expensive chemotherapeutic or local regional therapy or maybe immunotherapy, and you're still using very simplistic approach to assessing response. I can make a very strong argument that we're underestimating or we're poorly quantifying response using these conventional metrics. And that was the motivation to look for function, meaning, can we look at the entire tumor volume rather than one axial measurement? Can we look at morphologic changes, including the apparent diffusion coefficient, which is what I alluded to, or tumor enhancement? Can we assess in that tumor volume the amount of enhancing tissue? One of the things that I was amazed that we reached the same conclusion is that tumor burden is a huge metric that would determine survival, even without doing anything else. And it makes sense. But to date, we don't do that routinely. You think of all the advancement in imaging technology and tumor segmentation. With one click, you can get liver volume, And with auto-segmentation of the different tumors, you can get a percent hepatic involvement. And that in itself is a huge metric that can predict survival. So tumor volume is very important, and decrease in enhancement is very important, and changes at a cellular level. And oftentimes, as I was alluded to, it's not going to be one metric. It's a multi-parametric approach, meaning a small tumor that was viable. Otherwise, if the tumor is large and already necrotic, it is extremely unlikely for any therapy to be effective on an already necrotic tumor. So this is I'm very excited about the fact that you brought this up. I also want to be respectful of our time because I know that we're approaching the break. I can talk for another hour about tumor response, but I don't want to take too much.
I appreciate it. We know you're a world expert on that topic. Thank you so much, Dr. Kamel. I did want to, Dr. Kong, are you there? I was going to ask you one question if you are. If not, yeah, Dr. Archari has a question. Samik.
Hey, I was going to just add something to the concept of tumor burden, probably for both, locally advanced disease and metastatic disease. There's another measurement that we're starting to see and utilize with liquid biopsy. Mm-hmm. So looking at cell-free DNA and fractions, there was a nice paper in JCO Precision Oncology with Mitesh Barad. The first author was Dr. Junior, where they looked at the dominant clone of their patient's disease and looked at the cell fraction. Not even what mutation it was; it didn't matter. It was just whatever the dominant mutation was, and that fraction in the blood. We know it correlates with total body disease. So the more disease you have, the more tumor DNA you're going to have in your plasma. And they were able to stratify several groups. So being able to measure tumor burden radiographically, but also through blood, will be interesting to see how that becomes a clinical tool for both prognostication and to be determined how it could be helpful for prediction. But very interesting topic.
Yeah, great point, and a point that has broad applicability well beyond cholangiocarcinoma, and it'll be a very interesting tool in the future. One brief question for Dr. Kong, and then we'll break for 5 minutes. Dr. Kong, I know you talked about in your presentation about kind of, if I understood properly, like risk stratifying patients based on immunohistochemical staining and certain markers. And I was wondering if you are clinically using that information to inform treatment at all. So in other words, if someone had a specific pattern, immunohistochemical pattern, would that, be information be used in your multidisciplinary setting with your medical oncologist to perhaps inform, adjuvant therapy? Does that question make sense?
You mean what kind of biomarkers used for diagnosis or treatment?
Yeah, for treatment. If you're using some of the data you presented to actually inform treatment, it sounds like you're using it to risk stratify patients, but then are you taking that information and saying, aha, now we're going to maybe change the way we're managing someone based on that information?
Where we recommended immunohistochemical panels just for the ICC subtype classification, and if we to make a decision to the drug targeted therapy, we should do some special genes mutation detection. So immunohistochemical markers are usually used for ICC subtype classification, and the molecular alterations are used for drug targeted therapy. like IDH1
Yeah.
or 2 or FGFR2s. Yeah.
That's extremely helpful. And that actually, I think, is a perfect segue into our next talk. So with that, why don't we just take a 5-minute break? We will reconvene in 5 minutes. And at that time, we will begin the second session. So see you back in 5 minutes. Samik, are you there?
Yeah.
Fantastic. Just give it another few seconds here. Okay, why don't we get started? It's 11:16. So we have a real treat to have my colleague, my partner here at Ohio State, Dr. Samik Chowdhury, who is really a national expert in cholangiocarcinoma and in targeted therapy, and really, a go-to person to treat patients with this disease. So Dr. Chowdhury is associate professor here at The Ohio State University, where he's also the medical director of our cancer genomics lab. And as I noted, he really is not only but many people's go-to person, not just here, but from around the country here in the United States for treating patients with advanced cholangiocarcinoma. So Samik, we're really happy to have you here today, and I'm very much looking forward to your talk.
Well, thank you so much. I really appreciate the introduction and enjoyed the presentations today. Always like to talk about cholangiocarcinoma with our colleagues. And so as Tim mentioned, we'll talk about the systemic therapy advances that we are seeing. What are the standards? What's new? Where are we hoping to go next? And so we'll start with the types of cholangiocarcinoma. Just one slide about the anatomy and how that kind of affects the subclassifications in terms of genetics of cholangiocarcinoma. We'll talk about the first-line therapies and how that is evolving. And then we'll talk about the additional therapies for subsets of intrahepatic cholangiocarcinoma. So this is a diagram I like to start with. And again, I think many of our speakers are experts on this anatomy, but it really helps us think about the disease, the prognosis, the surgical approaches. So obviously intrahepatic, perihilar disease, extrahepatic disease, and certainly gallbladder. It helps us remember that when we see the clinical trials data, that we're really putting together a variety of diseases, and some of them behave a little differently. And it's important to consider as we look at the data that's coming out of clinical trials for systemic therapy. So a few take-home points based on that anatomy. Again, most clinical trials don't consider the difference when it comes to systemic therapy. When it's metastatic or we're looking at adjuvant therapies, they're all lumped together. The larger trials are international, and that influences maybe the inherent disease types. So anatomic types may vary, epidemiologic associations may vary. For example, fatty liver disease patterns may vary. So the types of cholangiocarcinoma will be a mixed bag. And again, this is something to consider. It doesn't mean we can't do these large international studies, because that's the only way we can do them. But it's something to think about when we look at, are there subsets of patients who appear to benefit more or less? And that may be a clue. And so until more recently, this has been the standard of care for advanced or metastatic intrahepatic cholangiocarcinoma, the combination of gemcitabine and cisplatin. And so compared to gemcitabine, this is the overall survival on the y-axis, time in months since randomization. What's exciting is there's been some new developments with combination therapy with immunotherapy. And so again, remembering that there's a mixed bag of disease here, but around 80% of patients get some kind of benefit, and it does translate into a survival benefit with the doublet combination. And more recently, in the TOPAZ trial that's been reported and published, we're starting to see other combination approaches. So there's an ongoing study including Abraxane, which is going to add some toxicity, but it may increase the overall response rate. So particularly important for patients who are young, who can tolerate triple therapy. We're starting to think about Abraxane and neoadjuvant therapy, where we're trying to get a good response so they can become a surgical candidate. And we'll talk about PD-1 combination therapy next. Other first line clinical trials that are happening are looking at, the sequencing of FGFR inhibitors. We'll talk more about those before chemotherapy, and is there a benefit to starting with those first line? So this is from ASCO this year and presented many places. The Topaz 1 study started initially with a smaller phase 2 study, and now it's become a 600 patient plus study, again, of the doublet chemotherapy, gemcitabine cisplatin versus gemcitabine cisplatin with the addition of durvalumab, a PD-L1 antibody therapy. And what's really exciting, and you can just see here with the red curve, which is the immunotherapy arm versus the blue curve, this is overall survival. And on the x-axis is time in months. And we're seeing what you've seen in the previous slides about gemcitabine cisplatin, but we're starting to see a tail of longer term survival. This is 27 months, but we'll see how these patients fare further out. But there's a subset of patients who are gaining benefit with immunotherapy, and the metrics here are on the right, overall survival. But what's interesting is that there's a tail, and we want to see how far this tail goes out for durable disease control for metastatic disease. So we're excited to see how far that goes. And the addition of durvalumab doesn't really add a lot of toxicity compared to, say, the addition of a third chemotherapy agent. Certainly there will be toxicities from durvalumab, but most patients tolerate that pretty well. So I know in the US, many of my colleagues and I have started to include durvalumab. The metrics for this approval around the world vary. And so this survival benefit doesn't always meet the criteria of certain agencies. And so we'll see what the follow-up data is, hoping that this could be approved in other parts of the world. But in the US, we're definitely very excited to offer this to first-line patients, even patients who had already started on GemCis who have been benefiting. I've added durvalumab as well after 6 months or so. And so we're really excited about this combination therapy. So immunotherapy in cholangiocarcinoma, when it's been used in a single agent strategy for second or third line, we know it's benefiting 5 to 15% of patients. And again, this is where that anatomy and diversity of disease comes into play. Although I would say this metric of 5 to 15 is probably similar to most solid tumors for metastatic disease getting, PD-1 immunotherapies. This is a nice review published in Lancet summarizing some of these immunotherapy studies. But again, the average benefit is around 5 to 15%. So before incorporating this in first-line therapy with GemCis, I would pretty routinely use single-agent PD-1 immunotherapy in the second or third line setting. One, patients are going to benefit, and two, it's pretty well tolerated, especially in cholangiocarcinoma where, second, third line disease, it can be, people can accumulate toxicities and lose their performance status. So this is, again, another slide, just summarizing the tremendous activity worldwide for immunotherapy, especially immunotherapy combinations, because the single agents had not been as promising with the 5 to 15% response rate. So we'll continue to follow these studies. Many are combining it with a second immunotherapy agent. Some are trying to modulate the immune microenvironment. A lot of activity happening in cholangiocarcinoma. And then returning to our anatomy, we'll shift over to sort of molecularly guided therapy. So instead of the chemotherapy, immunotherapy for all approach, we do know that cholangiocarcinoma is really one of the poster childs now for precision medicine. And we can associate some of these anatomical regions with some expected genomic targets. So FGFR, we're now saying 10 to 15%, IDH, maybe 15 to 20%, BRAF oncogenes about 1%, ERB family oncogenes about 1%, EGFR alterations, maybe less than 1%, and then NTRK probably less than 1%. And all of these are quite actionable. Some of them carry a tumor agnostic approval in the US, and then 2 of them have a cholangiocarcinoma specific drug approval. For the other anatomic subsites, that they have a different genomic profile. These tend to be more KRAS mutations, so very similar genomically to pancreas cancer, extrahepatic and perihilar. And then the gallbladder variety tend to have more epithelial growth factor gene alterations like ERB family and EGFR. So here are a couple updates on FGFR. For a disease, 5 years ago, we didn't have this many drugs. And so we've seen 3 years in a row an FGFR drug approved in the spring. First pemigatinib, second infigratinib, and now futibatinib, a covalent inhibitor as opposed to a reversible kinase inhibitor for the FGFR gene. Here's one of my patients on the infigratinib study with her pretreatment scan on the left with a nice response of disease in her lungs, and then her main liver mass responding very nicely. On average, we think about 70 to 80% of patients will benefit from an FGFR drug, with a smaller fraction getting a partial response, and then the majority of patients getting stable disease. But that might be changing. And so, we have a dearth of a great variety, thankfully, of second generation FGFR drugs. There's been some new data presented by Relay Therapeutics that was a lot of excitement about. And what we're seeing is higher response rates. And that's not unexpected. When we have a first-in-class kinase inhibitor, it's not necessarily the best in class. And so we've got the first-in-class inhibitors. And so maybe we're going to inhibit the targets more effectively now, as well as deal with resistance mutations that we know emerge in these patients. And so this is just highlighting maybe a 25% partial response rate and maybe a 50% stable disease rate with infigratinib in this waterfall plot. You can see highlighted here, and this is the dimensions and tumor response for infigratinib. So I want to highlight one patient from this study, just to kind of link the world of surgery to systemic therapy. Chemotherapy isn't necessarily the only neoadjuvant strategy we have. And so this is a patient who was deemed unresectable, had chemotherapy, didn't tolerate it very well, didn't have a response, joined our clinical trial for about 8 to 10 months, had to stop therapy for a number of reasons, but had a good partial response in the first 8 months. He was reevaluated for surgery, and he underwent resection. And so it's been a little more than 2 years post-operatively, and he's done well. We monitor him with MRI every 2 months with blood markers as well. And so unexpectedly, a patient who was pretty unresectable to start with had such a great response to FGFR therapy. And so I think we have to remember and keep our minds open. We never know what kind of responses we're going to get to second-line therapy in cholangiocarcinoma. And so beyond the FGFR alterations, which are for the most part in bladder cancer point mutations, so this is the FGFR gene in a cartoon fashion. In cholangiocarcinoma, we see mostly fusions, and that happens here in green. But we're starting to learn that there are other cholangiocarcinoma patients that don't have the canonical FGFR2 fusion, and they're actionable and treatable. And so we're starting to see patients have FGFR3 alterations. We're starting to see extracellular alterations in the immunoglobulin domains, small mutations, small deletions. And then another category that we've seen in pediatric cancers that we're looking now for in adult cancers, there are also tandem duplications in the kinase domain. So I think all of these are potentially, if observed in cholangio, potentially actionable and should be considered. And it's an area of active research from our team and others. So a couple highlights. I think we're near the end. I'll just stay on schedule. Molecular testing is essential for cholangiocarcinoma, and it can certainly improve outcomes, survival, and response rates with good side effect profiles. We should always include RNA-seq because that's the best way to detect fusions for the most part. We're still pretty tissue-based in terms of testing. I still recommend tumor tissue-based testing, cell-free DNA if you can't get tissue, but cell-free DNA we know can miss FGFR fusions, and that's well documented now. So if you've done cell-free DNA only testing and you can get blood, you can get tumor tissue, please consider getting tumor tissue for your patients. And the last thing is we should start to consider these atypical alterations that are not the classic FGFR2 fusion. I think got a couple more slides. So I'll just highlight a couple other targeted therapies. IDH has emerged in about 15% of intrahepatic cholangiocarcinoma. There's a survival benefit with ivosidenib. It's very well tolerated in terms of side effects. BRAF was studied in a larger group of patients, and here's about 40 of them, which is a subset that represents cholangiocarcinoma. Excellent response rates. This is published 2 years ago with Vivek Subbiah. And so again, well-tolerated therapy. This is something we should always be looking for. While it may only be a percent or so of cholangiocarcinoma, highly actionable and patients are benefiting. So to summarize, we're excited to see the new systemic therapy opportunities, potential for combinations in cholangiocarcinoma, highlighting again, molecular testing is essential. A lot of that's related to anatomy. We're seeing an evolving landscape of first-line therapy with PD-1 immunotherapy. We'll see where Abraxane data falls out, but we're excited about that. And then additional therapies, again, molecular testing is key for our patients with intrahepatic cholangiocarcinoma. And thank you for your time. I look forward to the question and answer discussion later. Always happy to talk about cholangiocarcinoma.
Thank you so much, Samik. Really appreciate what is a great overview of all the various therapies, cytotoxic, immunotherapy, targeted therapies that are emerging to treat this challenging disease. So thank you. Our next speaker is actually another very good friend, Dr. Bas Groot-Koerkamp. And Bas is an HPV surgeon in Rotterdam, Netherlands. He's an extremely accomplished clinical surgeon and also one of the premier researchers, clinical researchers in HPV surgery. Dr. Koerkamp has extensive experience in local regional treatment of tumors in the liver. And for that reason, we could have no better person today than to talk to us about the role of hepatic artery infusion pump to treat patients with intrahepatic cholangiocarcinoma. So Bas, I'll turn things over to you.
Thank you, Tim. Thank you for your kind words and the introduction and the opportunity to speak at this meeting. So it's always a bit strange to be a surgeon and talk about chemotherapy, but I think here the exception is that it's rather than the previous speaker talking about 100 different targets and different drugs. This is very simple. I'll just be talking about one drug that was FDA approved in 1971. And what I want to try is, I know many of you have heard of this, of floxuridine and intraarterial floxuridine, and I'll try to convince you that this drug has really been overlooked. I have one disclosure to make. I was a fellow at Memorial Sloan Kettering Cancer Center. So as you know, that's a center where this treatment has really been propagated, and I think all the former fellows from Memorial are kind of disciples spreading the word. But nevertheless, I'll focus on the data, and I'm looking forward to learn what your thoughts are. So what is the rationale for intraarterial chemotherapy in general?
Hey, Bas, Bas, sorry to interrupt. I don't see your slide. Yeah. If you could share your slide.
Sorry about that, Tim. Thank you.
There we go. Thank you, my friend.
Thank you. So the rationale, why intraarterial chemotherapy? Well, as most of you will know, liver tumors are perfused mainly by the hepatic artery rather than by the portal vein. And this has been extensively studied many years ago. And what is particular about regional chemotherapy compared to any other organ is that some drugs are extracted by the liver during the so-called first pass effect. And this allows a very high dose in cancer cells with minimal systemic toxicity. It does depend which drug you use. So this is a table with just a few common drugs that have been used for intraarterial treatment. And what is very striking here is that there's one drug called floxuridine, also known as FUDR, that if you look at the exposure in the cancer cell compared to when you compare systemic treatment with intraarterial treatment, it's about a 200-fold exposure. And that's, I think, one of the main premises of this treatment. So how does it work? So because of the short half-life, the best way to administer intraarterial chemotherapy of floxuridine is to do a surgical placement, which you see on the left panel here, of a catheter with the tip just at the flow of the hepatic artery. So this catheter is positioned in the gastroduodenal artery. And in the right panel, you see how it's important to have the tip exactly at the flow. Because if you put it too far into the hepatic artery, it may cause a hepatic artery thrombosis. And if you put it too far away from it, you can get pooling from the chemo, which can cause, which can result in pseudoaneurysm and hemorrhage. So this catheter is connected with a subcutaneous pump. This pump has a 35 cc reservoir with a constant flow rate. We are using this Trichomet pump, but in the US, typically the Cotman pump is used, but it's otherwise very similar. And so this pump has two membranes. The membrane on the left can be accessed to fill the reservoir. And on the right side, there is a membrane where you can do immediate perfusion of the catheter. For example, to do a bolus of heparin or to do any sort of study you would like to do from the catheter positioning. So the way most centers use floxuridine is with 6 cycles. 2 weeks the pump is filled with floxuridine and 2 weeks with normal saline. So just like any other treatment, this treatment has complications which have been very well characterized because it has been used for so long in thousands of patients. So one is a pump pocket infection, which can mostly be treated with antibiotics. As I mentioned, catheter insertion in the artery needs to be done meticulously. And if it's done meticulously, the risk of bleeding is very small, less than 1%. I think probably the most important and impressive complication is biliary sclerosis. So while the floxuridine treatment has really no effect on hepatocytes, it does have effect on cholangiocytes and can cause biliary sclerosis. And in some patients, this may even require biliary stenting. Hepatic artery thrombosis, I mentioned, I think is mainly associated when the catheter is too deep in the hepatic artery. And another concern is duodenal or gastric ulcer disease. And the explanation for that is that there are some tiny branches that run back from the hepatic artery to the duodenum, the pancreas, and the stomach. And these need to be dissected and transected with the pump placement. And if that's not done, then the floxuridine with a very high dose can cause ulcer disease. But in the end, this treatment is very feasible, which we also showed in the Netherlands in a recent study, and 95% of patients have a functional pump even after 6 months. So while the focus of this presentation is on intrahepatic cholangiocarcinoma, I just want to present one slide on colorectal liver metastasis, and I'll focus here on the adjuvant setting. And I just want to show this because I'm totally surprised that these results are not more widespread and known. So out of the many trials, I picked 2. One is a study where Nancy Kemeny, who has really done most of this work, has combined her results from 4 different phase 2 trials. So these are 300 patients. They had really a lot of disease, and the 10-year overall survival was 61%. So of course you can argue, well, these were very fit Sloan Kettering patients, but I do not know of any series that gets even close to 60% 10-year overall survival. When I was a fellow at Memorial, I put together all the patients who had a resection for colorectal liver metastasis, and about a third of those had a pump. And in propensity score analysis, after adjusting for more than 10 factors, the adjusted hazard ratio was 0.67. So let's move back to intrahepatic cholangiocarcinoma. So I was very fortunate that I do not have to spend many slides on the background of intrahepatic cholangiocarcinoma with these amazing previous speakers today. But just a few things I want to mention that are important to understand why to use a pump in these patients. Number one is that most patients present with unresectable disease. And of those patients, the majority has disease limited to the liver. And a very interesting paper I only discovered a few years ago from MD Anderson looked at about 500 patients with intrahepatic cholangiocarcinoma, all stages, regardless of treatment. And what they found is that the vast majority of patients actually die from biliary obstruction with or without liver failure. So they do not die from peritoneal disease or lung disease or widespread extrahepatic disease. The vast majority dies from disease in the liver. Well, what other targeted treatments do we have? Of course, we have thermal ablation. We know well for liver tumors, but I think it has an extremely limited use because the majority of these lesions are too large. And then there are embolic treatments like TACE or Y90. And although some of these results are to some extent promising, I think if you look at the most recent systematic review, the median overall survival is disappointing. So this slide was already shown by Dr. Roy Chowdhury, the famous trial from Juan Vallée, already 12 years old. And fortunately, a few years ago, a subgroup analysis was performed of only the intrahepatic cholangiocarcinoma subgroup of all the ABC trials. So they put together all the ABC trials and looked at the subpopulation of patients who had unresectable liver-only intrahepatic cholangiocarcinoma and received GEM-CIS. And I'm showing this because I think it's important result, because I think this is really the benchmark if you want to do any local regional treatment. So this is what you get if you only treat these patients systemically. The 3-year overall survival, you have to look into the supplemental to find it. It's only 3%, and the 2-year overall survival is 25%. So it is important to realize this is actually better than, slightly better than for the other cholangiocarcinomas. So what is the data for hepatic arterial infusion pump chemotherapy for intrahepatic cholangiocarcinoma? Memorial has done 3 phase 2 trials, none of them randomized, all relatively small sample size. They had small differences in inclusion criteria and treatment, but I think they're very comparable. And I think the results are quite consistent. So the response rate is high. And actually, if you treat these patients, progression of disease in the liver is rare. And these patients with a pump, they rarely die from disease progression in the liver. The median overall survival is way superior to systemic treatment alone. But I think what is most impressive is the 3-year overall survival. With the most recent study, even a 3-year overall survival of 43%. So remember, in the ABC trials, this was only 3%. So it's amazing that these results do not end up in guidelines, because 43% versus 3% is quite a difference. And people have argued we need an RCT. The RCT I'll show you is coming, but I'm not sure whether I would like to be in that RCT. So we recently also did a meta-analysis, which will not surprise you, is mainly based on studies from Memorial. And we found a similar results with even a 5-year overall survival with long-term outcomes of 10%. So that's not even that much worse than for surgery, because Tim Pollock showed you that how the results for surgery, especially for multifocal and node-positive disease, reminded him of pancreatic cancer. So we actually looked into, together with the help from Tim, at this subgroup of patients with multifocal disease. And it has been argued that even though in the AGCC staging it's stage 2, we may have to consider this stage 4 disease. A recent large study in hepatology showed that the median overall survival of multifocal intrahepatic cholangio is only 11 months. So what did we do in this study that was recently published in JAMA Surgery? We had 140 patients who received intraarterial chemotherapy and 178 patients who had a resection, all of them for a multifocal intrahepatic cholangiocarcinoma. And if you then look at table 1 of this manuscript, you'll see that almost with every known biomarker, the pump group had more advanced disease. Very strikingly, there's a big difference in postoperative mortality, and the median overall survival was similar. The survival curves were overlapping. So these are the survival curves, and we split it in 2 or 3 lesions and more than 4 lesions. And I think the take-home message from this is that if you have a patient with a low surgical risk, so a relatively fit patient who only needs left hemihepatectomy, I think it's best to proceed with resection and consider maybe adjuvant pump treatment. But if you have a high surgical risk patient, and this is actually the majority of patients, these are very often octogenarians, very often they require a right or even an extended right hemihepatectomy. I think it's better and safer to treat these patients with pump chemotherapy. So these 3 phase 2 trials I just showed you, all from Memorial, we tried to replicate their results. And in only about 2 years, we included 35 patients and a single-arm study. We completed accrual January this year, and we'll hope to be able to present the results to you soon. But so far, the survival curves are overlapping, and it looks like we're also going to get a 3-year survival of 40%. And it's important to realize that we really included all comers in this study. So the study is real life and even includes 1 patient that died from COVID 3 weeks after pump placement. And nevertheless, the results are really impressive. So this is the international RCT I just mentioned, has already started at Memorial, and Oslo and Erasmus and Amsterdam in the Netherlands are going to participate after figuring out all the administrative hurdles to do so. So in conclusion, ladies and gentlemen, for unresectable intrahepatic cholangiocarcinoma, it's important to realize it's mostly confined to the liver, and most patients die from biliary obstruction and liver failure. And the 3-year overall survival is only 3% with systemic chemo, and it is improved, further improved with targeted treatments and immunotherapy. But I think with intraarterial chemotherapy, the results are way more impressive. 60% partial response, 40% 3-year overall survival, and the 5-year overall survival even 10 to 20%. So how does this look in the future? And I left out targeted treatments from here and immunotherapy, because that's way too complex for me to understand. I think if you have a solitary lesion, you're best off with a resection. At the other end of the spectrum, if you have metastatic disease, clearly you're best off with systemic treatment. It's the group in the middle, definitely those with more than 3 lesions, but probably also many with multifocal disease, 2 or 3 lesions, and nodal disease. I think these patients, and this is probably a large group, probably a third of all patients, in my opinion, is best off with hepatic arterial infusion pump chemotherapy. Thank you very much for your attention.
Thank you very much, Bas. So that was a great talk, and I really enjoyed this session. I'd like to open it up for questions. If I get a story, I'm going to start with a question with you, Bas, just to follow up. I know today we asked you to talk about hepatic artery infusion pump. I was just wondering if you could comment, though, on other local regional therapies, if you think there's any role for Y90. I cited a case where I did use Y90 on that patient, or even is there a role for SBRT to treat patients with ICC? Maybe you can comment on that, and then I'll have a question for Samit.
Yeah, thank you, Tim. Regarding SBRT, our radiation oncologists are typically concerned for liver damage, because these lesions are so large typically, so they need a very big field. Often the colon is adherent to the lesion, or the stomach is adherent to the lesion. So we rarely use SBRT. We do use Y90, and unfortunately, attempts have been done to do randomized trials for this. But what I understood is that they failed to get to complete accrual. The phase 2 trials show some evidence. I think it's not even close as good to hepatic arterial infusion pump chemotherapy, but we do use it in patients who cannot get a pump, or in patients the way I look at this disease is I try to predict what is going to kill the patient. So if a patient has a large lesion that is encroaching on the liver hilum, I think we should do anything to get the liver lesion smaller. And I think Y90 is a good option. If you have a patient with tiny lesions in the periphery of the liver, these patients are more likely to die from peritoneal disease and pulmonary disease. But I think the majority will get in trouble with a tumor encroaching on the liver hilum.
Thank you. I believe Dr. Washington has a question. Kimberly?
Very interested in pump chemo for intrahepatic cholangiocarcinoma. And one of my questions, though, is we've got data for colorectal liver mets, and the fact that in those patients, you can get somewhere near to 30% converted to resectability in those patients who are unresectable at the time of pump placement. But do we know that number for intrahepatic cholangiocarcinoma or something similar to it?
Yeah, that's a very good question, Kimberly. Thank you. I probably should have mentioned it in my presentation. So quite consistently, that's about 10%. So that has been about 10% in the studies from Memorial, and it has been about 10% in our study. The thing, though, that is very different, I think, with colorectal liver mets is in colorectal liver mets, you still have a probability, even though small, but it can be 10, 20, 30% of actually curing these patients. And with intrahepatic cholangiocarcinoma, we know that they will all die from their disease. I mean, like Tim showed, even the resectable ones, the cure rate is 10%. And so the ones that are unresectable, they will all die from peritoneal and lung disease. And that's what we see in these pump patients. So to me, the benefit of liver transplant or resection after a pump is very limited, because the pump controls the liver disease, and any other treatment needs to deal with metastatic disease. Does that make sense?
Thank you.
Yes, Professor Ramadori.
One question. You showed that the 3-year survival with systemic 5FU administration is 3%. Can you tell us which kind of how much 5FU and how it was administered as a bolus or infusion, and how was the total, amount of 5FU administered in those studies?
I think I may not have explained this well, or I don't understand your question well. Let me go back to this slide. This is the slide of systemic treatment. And
right.
This is a subgroup analysis of the ABC trials. And all these patients had systemic GEM-CIS.
Yeah, I mean, 5FU, the efficacy is dependent on the kind of administration. If you use a pump for 48 hours, you can use a higher amount, higher dose, and get much more efficacy. So if you go back and patients have been treated with 500 milligrams as a bolus, and of course it doesn't work. So the comparison has to be done, with the systemic therapy, with the appropriate dose and the appropriate way of administration. As is now coming out for pancreatic cancer, for colon cancer, if you use infusion every 14 days, 2.4 grams per square meters, you get a much higher efficacy.
I'm afraid I do not understand your comment.
the question was, you know, those studies where the 3-year survival was 3%,
Yes.
which doses was used for 5FU and how it was administered?
So
Okay.
the slide I'm showing now with the 3-year survival of 3% is not about 5FU, not about fluoxuridine, not about intraarterial chemotherapy. It's the data from the ABC trials about systemic GEM-CIS.
Systemic? Say it again.
Systemic GEM-CIS. So this is a subgroup analysis. So this slide shows the ABCO2 trial, right? But this is for any cholangio, including gallbladder.
Okay,
And this slide is a subgroup analysis that the ABC group published, and all patients received GEM-CIS for liver-only intrahepatic.
Okay, then forget it. But 5FU is effective also systemically. So if you do treat those patients with 5FU systemically, it may be as effective as intraarterially, which is an invasive way of treating persons. So it can be effective. Of course, if you have a cirrhotic, if you have ecstatic people with bilirubin about 15, you cannot do it. But on the other hand, you can use capecitabine. Capecitabine, you can give it orally. It could be as effective as the intraarterial treatment. I mean, it was just a comment.
Yeah, maybe we can get Samik into this conversation as our resident expert medical oncologist.
Okay.
Yeah, I agree. I think thinking about systemic versus local delivery. People can tolerate capecitabine and 5FU systemically pretty well from my point of view, every 2 weeks. On the other hand, the convenience of having a monthly dosing, perhaps of intrahepatic, as well as I think the key feature on this slide, very nice presentation, by the way, is the 200-fold, localized concentration of drug. You could never, if that was the dosing you use for the equivalent of 5FU, that person would never recover their blood counts, right? And so I think that's really the exquisite opportunity for a local delivery. I was going to add a comment. Tim mentioned, other modalities for local non-surgical treatments. As far as radiation, the other modality, I don't often see it because most of my patients come to me with disease everywhere. But when you've got liver dominant disease only that's not resectable, certainly the emergence of proton radiation has become a useful tool. There was a nice study and some smaller, series showing that proton radiation can be well tolerated, pretty good at local control. A handful of people would progress, and certainly, of course, if they're going to progress, most of them progress systemically. So I think that's another important option as proton radiations, become more available. It's quite expensive to build a proton center, but we're starting to see more and more applications, again, with lesser toxicity, which is the chief concern for radiation to the liver, especially big masses in the liver. But I've had at least a handful of patients who've had, more than half of their liver radiated and have done well with proton. So anyway, just wanted to mention the proton radiation angle here. So
thanks, Mick. Hey, Smik, I had a question for you. It's been my experience that we typically treat these patients in the pre-op setting if they're unresectable or borderline biologic candidates, kind of with standard therapy first, and then move to kind of targeted therapy, as second line. Can you just talk about like moving some of this targeted therapy forward, and the importance of getting the molecular and genetic data up front, and how comfortable are you now just to like start off with a targeted therapy if we're looking for a response as surgeons to try to get them to the OR?
I think that's a great idea. Treating smaller disease that can be removed is a lot better than treating disease everywhere. And so far, I gave an example today of a patient who had failed GEM-CIS and was still not resectable, and we gave him an FGFR inhibitor. So that's going to be part of a case for series that we're going to share from that study with three total patients who had a similar outcome where they were able to go to surgery when they were previously not resectable for a reason usually related to anatomy or burden of disease. And I think it's a great idea. We've not yet seen combination approaches with chemotherapy and FGFR drugs. There's a little bit of clinical trial evidence and data out there that's not published, but that's a great opportunity. We know that FGFR drugs plus GemCis can be tolerated. And so if you have a patient who's positive, I think it would not be unreasonable to try, if you're trying to get that partial response, to get them to a safer and better or feasible resection. Absolutely. I'm very much in favor. Again, these are rare cancers to begin with, and we may not have a study yet of GemCis FGFR for neoadjuvant therapy, and we may not. The current studies for first-line therapy, randomizing patients to chemo versus FGFR, they're struggling to recruit patients across the board, and part of it because of the delay in therapy. For in that type of metastatic disease setting, people are worried about the disease burden and delaying therapy, and so those studies have struggled. But we've already seen evidence that the combination is safe. So I think if you have a patient who's marker positive FGFR, for example, I think it'd be a great idea to include it all at once to get them their best chance of surgery. Very much in support of that. So
Thank you. Boss, we're at time, so one last brief comment from you.
Just a question to pick on your expertise of Samik and Tim. So if you have a patient with FGFR rearrangement with a huge response on targeted treatment, young fit patient, the liver, all the lesions much smaller, but there's one aortocaval node that's now 8 centimeters, and it's the only lesion that's growing. Would you take it out?
The node is 8 centimeters. That's a big node.
It's an 8 centimeter aortocaval node, and it's right at Treitz ligament. It's at the left renal vein. So it's going to obstruct the duodenum, and all the other lesions are much smaller.
So if this is a real patient, I would try to get a biopsy or try to do a liquid biopsy assessment, and maybe they could be switched to one of the second generation FGFR drugs if there's a resistance mutation. If there's not a resistance mutation, but they may have acquired something else. So we've seen, BRAF, PI3 kinase that could also be co-targeted with an FGFR drug. So something's goofy with that lymph node, and it could be,
it's taking it out.
And I would try to biopsy it, do liquid biopsy, and try to treat it systemically at 8 centimeters. I wonder if there's more disease than that one lymph node.
So just we have to wrap up. So I agree with everything Samik said. So I think looking for some type of other targeted mutation, right, for second line therapy that you could use, and I would proceed along that way. I think I've already demonstrated in the patient I showed with the super large tumor and the ascites and the CA19-9 over 100,000 that I have an appetite for taking people to the operating room if they've had like a good response from chemotherapy, even though we know that their prognosis could be guarded. But frankly, if you can do it safely and they've had a good response otherwise, boss, I probably would. I would do it.
You could also follow the systemic therapy after the surgery. So get the lymph node out, test it, and you could tailor the adjuvant therapy accordingly and continue an FGFR drug if you think there's risk for recurrence too. So,
Professor Vardy, this is a robust discussion. I don't want to cut you off. So if you have a brief comment. I don't know. Hand up.
Yes.
Professor.
I have some question. Yeah.
Okay, Feng, how about let Professor Vardy go, and then I'll get to you. Did you, Professor Vardy, are you there?
Yeah, I am here.
Very good. So I have a small question about the systemic for ICC, because my question is about Lloyd Hurry about the, what is the opinion about the TKI in ICC? Because, we have a nationwide study to discover that the birth ICI plus chemotherapy, GC, or plus TKI or anti-vascular agents can achieve a similar survival benefits in advanced ICC. So because, there was very, very little studies on TKI on ICC, even for BTC. So what's your opinion about that?
Smeek, do you want to comment on that?
So could you,
I think it's TKI.
which TKI was that? I'm not.
Yeah, TKI, Lenvatinib. Lenvatinib is much commonly used. Yes.
Yeah, so I'm not familiar with the study, but I'd be very interested to hear more about it, maybe offline. Lenvatinib, is one of those weaker FGFR drugs and has other activities, so it'd be interesting to see its efficacy. But I apologize, I'm not familiar with the study, but I'll pass it back to Tim as the moderator.
Okay. And then Dr. Vardy, just one last brief comment because we really do need to wrap up. I know
just keep it for the want of time, very brief. Yeah,
Okay.
so I just wanted to know your thoughts on preventing futile resections in IHCCs and also the perihilar cholangios. So we assessed our data for last 10 years of about 180 resections, and we found out quite a bit of number of 20 to 30% do recur in early 3 to 6 months. So any predictive preoperative parameters, models to assess to prevent such futile resections?
Yeah, so I guess just briefly, I think I highlighted, I think it's a little bit different. In my mind, I think for intrahepatic cholangio, frequently it's futile because of biology. You're technically able to do the operation, but the patients recur. So I think of biologic futility, if people have a large tumor burden, if they have multifocal disease, if they have evidence of lymph node metastasis preoperatively, I think the chances that you're going to derive a long-term survival benefit are probably lower. So I'm going to work with Smeek to try to come up with a multimodality approach to that patient. I think for perihilar, it's different. Frequently, it's hard to tell whether they're truly resectable or not based on preoperative MRI, even ERCP or cholangioscopes, et cetera. So that's more of a technical issue, in my opinion. You can be challenging when you get in there. There may be arterial involvement, venous involvement. So those patients, I don't use a lot of preoperative chemotherapy. I just use, MRI, MRCP, spyglass, and then if it looks resectable, I'll try to resect them. Okay, so we're going to have to conclude there. I do want to let Professor Ramadori have the last word. I want to thank all of the speakers for their wonderful talks. I want to thank all the participants for the wonderful discussion and your participation. And I want to thank Professor Ramadori and Hepatoma Research for hosting this webinar today. So, Giuliano, I'll turn things over to you for the last word.
Yeah, thank you, Tim. You did a really great job. Thank you to everyone of you who gave your talk. And I think we had made a little progress today. We have, achieved what the aim of hepatoma research is to get people together and increase knowledge and get new ideas to improve the quality and the prognosis, the quality of treatment and the prognosis of the patients. So also I wish to thank the audience. We had about 40 people in the audience. So it's a big achievement from all of you who gave really impressive talks. Thank you very much. Have a nice day or nice evening.
Thanks, everyone. We'll sign off with that. Stay well. Hope to see everyone soon. Bye-bye.
Thank you, Victoria.
Thank
you, Ada.
Bye. Good to see everyone. Feng, good to see you, my friend. Hope things are well.
Thank
in
you.
Shanghai.
Okay, thank you.
Okay, bye-bye.
Okay, wait a minute.
See you next time.
Can we take a picture together? And everybody, can you turn on your camera and we can make this pose like me and I will see the 1, 2, 3. Okay.
I can try.
Yes. Everybody, open your camera. 1, 2, 3. Okay, perfect. One more time. 1, 2, 3. Okay.
Okay, thank you.
Thank
Bye-bye.
you. Bye-bye. Thank you.